it's important for oncologists to partner with pathologists, particularly for these high risk, high impact gene expression profiling tests for breast cancer. We have a robust discussion at our breast tumor boards and in our clinical conferences regarding the patients who are discussed there. And it's interesting to watch the evolution of what has happened over the past 10 to 12 years. Typically in the past, before there were any of these gene expression profiling tests, each discipline, medicine, surgery, radiation, and pathology would discuss the aspects of what they had tested for. And fundamentally, the pathologist would weigh in on what they felt was the grade of the tumor and the stage, which was an indicator of tumor aggressiveness. And it really is. Nothing has ever changed that. Decades of clinical trials have attested to the importance of patient age, tumor size, tumor grade, and lymph node status, as well as hormone receptor status and HER2 status. So we would weigh in with this information, and a decision then would be made whether the patient would receive endocrine therapy only or endocrine therapy plus chemotherapy. But nowadays, the next layer, if you will, of testing that has been put on this are the gene expression profiles. And as I mentioned, almost always these gene expression profile tests correlate very nicely with what the pathologist has put together in terms of traditional clinical pathologic factors. So in essence, it's sort of an additional tool that our oncologist colleagues use to assess the patient. And it's also a meaningful tool for pathologists also to learn how to better classify these tumors in some instances. There may be some information in those tests that actually aid the pathologist in their assessment of the tumor. So it really comes down to a multidisciplinary approach at our tumor boards, this free flow discussion of all the gene expression profiling tests that are available,